So as people file in, I'm respectful of time. So why don't we go ahead and get started as people continue to come in. My name is Arno Kumigai. I think many of you know. I have the absolute privilege and pleasure of hosting the citywide medical grand rounds for the Department of Medicine and the University of Toronto. Today, I'm actually going to be turning the wheels over to folks from the Sinai for a special lecture, the Berris lecture. And they have a special guest today who I'm absolutely delighted to hear. But I will turn it over to the physician-in-chief, Dr. Chaim Bell, for further introductions. So Chaim, all yours. Thank you.
Thanks, Arno. And what a nice day. It's a special day at Sinai. It would have been even special if it wasn't during a pandemic when we could actually have physically seen people and hosted Dr. Gavin for what we usually have is a lunch and meeting of other people here. But right now, I just wanted to talk a little bit about Dr. Barney Berris, who was born in 1921 in Toronto to Eastern European Jewish immigrants. He graduated from the University of Toronto, Faculty of Medicine in 1944, and was involved with the World War efforts at that time through the Royal Canadian Army Corps. He completed his postgraduate training in internal medicine at the University of Minnesota in Minneapolis, because at that time, the residency program wasn't open to Jewish people in Toronto. He returned to Toronto at that time and really subsequently broke down a lot of the barriers faced by Jewish doctors in Canada at that time. He was appointed to the Toronto General Hospital in 1951, the first Jewish doctor appointed there. And then he came to Mount Sinai in 1964 to become the chief of medicine very soon after the hospital achieved its full university affiliation. He was known at Sinai as the doctor's doctor and renowned for his outstanding clinical acumen and exemplary teaching. He served as chief of medicine until 1977 and continued to practice and teach thereafter. He has been credited in helping establish the academic foundation of the department at that time. And in 1998, in recognition of his outstanding and exemplary contributions to medical education, the University of Toronto and Mount Sinai Hospital, his name was chosen to represent the partnership in education between Mount Sinai Hospital and the University Health Network for the newly named Whiteman Berris Academy, which the joining of names represented both Dr. Kager Whiteman, chair of medicine at the time, and Dr. Berris as the chief of medicine at Mount Sinai. And colleagues at Mount Sinai Hospital helped establish the Barney Berris Lectureship in Medicine, as well as the Barney Berris Chair of Cancer Research at the Weizmann Institute of Israel in his honor. So I'm going to pass it over to our own Bernie Zidman to give the introductions to our illustrious speaker for today. Thank you very much.
Thanks, Chaim. It's indeed a pleasure, privilege, and honor to introduce my good friend and colleague, James R. Gavin III, who has had an incredible academic career and achieved many accomplishments, which he continues to do. Currently, he's a clinical professor of medicine at Emory University School of Medicine and is Chief Medical Officer of Healing Our Village, Inc. He served as president and CEO of Morehouse School of Medicine in Atlanta. He was a senior scientific officer at the Howard Hughes Medical Institute. Dr. Gavin is a past president of the American Diabetes Association and is the first African-American elected to that position. He was named a living legend in diabetes by the American Association of Diabetes Educators in 2009, received a Lifetime Achievement Award for Diabetes Research from the American Diabetes Association in 2015, and a Lifetime Meritus Achievement Award from the National Medical Association. In addition to his excellence and accomplishments in research, teaching, academic leadership, he was early to recognize the importance of societal determinants of health. Indeed, as an example, during the Obama presidency, he was founding chair of Partnership for a Healthy America, working with FLOTUS. Jim, this is a Canadian audience, so I'll have to define what FLOTUS was. The First Lady of the United States, namely Michelle Obama, who we worked closely with in the context of her Let's Move initiative. And one can summarize Jim's personality, accomplishments, and what he has done as a true mensch. For those who may not know what that term means, it's someone to admire and emulate. And he and Barney Berris would be close friends if that opportunity presented itself. So we're looking forward to your presentation. He said to me, they don't want to hear about me, they want to hear from me. So let's hear from you. And the topic, of course, is the quest for closing disparity gaps in diabetes care, implications of biology versus racism. Jim, it's all yours.
Thank you very much, Bernie, for that very kind introduction. I want to make sure that the slides can advance. Christian is there. Here we.
That looks good now.
Yeah.
Back up to the title.
Okay. Well, thank you very much, Bernie, for that very kind introduction. Let me thank all of you. And I may be one of the people on the line who knows both what a FLOTUS is and a mensch. So I'm off to a reasonably good start. Let me say that I deeply regret my inability to be there in person because Toronto is one of my favorite cities to visit, especially when the temperature is on the warmish side. I'm excited to talk to you about this topic today that Bernie has also already introduced. I have no disclosures related to the content of this presentation, but I do want to say that in the course of preparing for this talk, as I learned a bit more about Dr. Berris, it turns out that we had some peculiar parallels, which I sort of briefly summarized, because here we are, according to our designations du jour. In the 50s, he was a Hebrew in Canada. I was a Negro at Atlanta. And we both grew up and developed in the context of nurturing environments with him, in his case, Jewish friends, me, in my case, with Black friends, with the support of the Black community. And we did reasonably well in our academic pursuits. But in the course of our career aspirations, he encountered, as you have heard, a widespread anti-Semitic bias, which served as a hindrance to his career aspirations and progression, which caused him to have to do some extra moving around for training and the like. In my case, it ended up with a confrontation with a professor in the middle of my PhD pursuit, who in a clandestine after-hours meeting asked me who had written a paper that I had submitted because the quality of the work was, quote, really high. Now, those are the kinds of things that we encountered, and they represented examples of the kind of ambiance of bias that were not uncommon, but through persistence, performance, and advocacy, clearly Dr. Berris has established a legacy that is more than admirable, and I'm still trying. What I would hope to do is first to establish a context for our discussion today, because if we're going to have substantive discussions on efforts to reduce or eliminate disparities that have been generated in the setting of long-standing inequalities, we have to establish context for that kind of discussion. And it's very clear as we look on our joint histories that the legacy effects of our historical practices affect us all. And it doesn't really matter what the national border is. It begins with issues related to the designation of race and the assignment of differences based on such designations. And it's complex. And we've seen disingenuous methods that have been used to establish or justify, quote, racial differences. Here we see a photograph of a Nazi doctor who is measuring the nose with calipers of an ethnic German. And we all know that the Nazis developed a pseudo-scientific basis for making designations of race for the purpose of defining superiority. Now, the definitions that we embrace in this universe of talking about race are not exactly definitions that reek with precision. Nationality is simply where a person was born. A Chinese born in Kenya is a Kenyan national, and so forth. Ethnicity really refers to the designation of people united by a variety of traditions, behaviors, customs, and religious traits. And these are people who regard themselves as different. Race is intrinsically more complex. It refers to biologically engineered features, and it can include a number of metrics. And it is not as precise as we would like it, and we're still trying to get our arms around what this really means. Now, the inherent complexity of defining the implications of race and racial designations is that the complexity is often heightened by the degree to which it is often bolstered by what I call undeserved credibility, unsubstantiated by science. And we see an example of this complexity that is contributed by the whims and biases of larger than life persons who have big platforms of celebrity, like James Watson, who was a Nobelist, the co-discoverer of the double helix of DNA. And Watson actually had unsubstantially, he advocated unsubstantiated claims about genetically determined inferior intelligence of Blacks and Indians, talked about the genetic-based conformity of Chinese, and he had a lot of credibility of his views based on what he'd done and who he was. This is unfortunately one of the reasons why he became persona non grata increasingly in his later years. Now, this kind of pseudoscience and economically driven bias has facilitated catastrophic and colossal practices of racism undergirded by sentiments, while clearly not scientific. They still found support in the social, medical, and political establishments. And such was the case with American slavery, where the view that was generated that dissimilarity was equivalent to inequality. And this practice, centuries in duration, resulted in a cruel and bitter past with a legacy. Now, this was a practice that, as you know, was firmly established and anchored in the concepts of dehumanization and innate superiority. Slaves were bought, sold, and traded in well-established markets. You see here what was Atlanta, Georgia in the 1800s, and you see this marketplace where there was the auction and sale of Negroes, right in the middle of other business establishment. So it's not surprising that many themes and practices that were found in the actions of the Nazis and other settings of structured, politically embraced, scientifically defended racism had their origins in practices like slavery. So in the context of today's presentation, there are clear-cut legacy effects of such practices. And chief among them is the enduring existence of a variety of disparities. Indeed, there is this well-established, thoroughly documented history of disparities in both health and healthcare in the US, driven by complex factors that include elements of biology, behavior, socioeconomic status, and a whole host of policy issues. There are lots of questions that remain underexplored. And so we need a lot of additional research and new approaches. The catastrophic effects of the pandemic and the resultant issues that have arisen from it have brought into sharper focus the need for greater attention to the underlying reasons for these disparities, including the historical ones. And this has generated for us in this country certainly a moment in our history where the urgency for solutions to these lingering problems is critical. However, if we're going to have meaningful engagement of this quest, it begins with confronting uncomfortable truths. Now, certainly in the context of our discussion today, you there in Canada are confronted by your own set of uncomfortable truths because of the legacy of colonialism. Now, it has generated a legacy of issues that have effects on patients and for providers. The historical oppression that comes out of such a history, the unresolved trauma that is persistent, and the legacy of mistrust are all issues that we have to constantly deal with. And I certainly commend you as Canadians for the vigor of your efforts in recent years to address many of these past wrongs. We're all struggling to try to overcome and get it right. But with regard to context, it is absolutely clear that as neighboring nations, we share a shameful history that has generated substantial and persistent health inequities in our citizens of color. Now, when we think about disparities in health and healthcare, diabetes figures predominantly in such discussions. And we begin our exploration of this association with the recognition that diabetes is a disease that is more common by far in marginalized people. And it doesn't matter whether that marginalization derives from bondage or a history of oppression. The fact of the matter is the downstream consequences are the same. Poor self-esteem, high rates of poverty and stress. In other words, an increased burden of the social determinants of health, generating marginalized people, one of whose legacies is poor health, increased chronic diseases like diabetes. And we'll talk a bit more about this, but it is very clear that the wealth gap, which is one of the key legacy issues of marginalization, that wealth gap drives the health gap. Now, diabetes continues to occupy a central posture in our focus because it is persistent and it continues to rise in its prevalence and in its burden. Now, we see here how it's expected to increase over the next couple of decades all over the world. And this is not new information for any of you. And it clearly is the case that when we look at the history of diabetes, just going back 4 decades, for example, this used to be a disease of the rich. And you can see evidence of that as you look at the prevalence of diabetes in the 1980s was a little higher among the higher incomes. But as we move into more current times, it has increasingly become a disease of the poor and marginalized, where evidence is really strong that the wealth gap continues to drive the health gap. And this is also true here in I wish I were there, in Canada, where there is clear evidence that there are notable differences between the rates of diabetes in Indigenous and non-Indigenous persons there in Canada. Now, it's not just the increased prevalence of the disease that gives us cause for such concern and that creates the need to have these discussions about diabetes-related discrepancies, but there are notable differences in the complications, the morbidity of this disease. Wherever we find increasing prevalence rates of diabetes, we see increasing trends in diabetes complications. Now, the fact of the matter is that when we look at racial disparities, these are persistent in time, but they're not proportionately distributed. Not only is there greater disease prevalence, but there is more burden from complications in marginalized populations. The question that has real urgency is why? Why are these disparities so dominant and so persistent? Well, the why question becomes urgent because it's only the degree to which we bring clarity to that we can inform the direction of remedies. Now, in the US, we've seen over and over again evidence for disparities, not only in the prevalence and occurrence, but disparities in the quality of care that targets reduction of these complications. We see here, the recommendation has been longstanding that as a core of diabetes care, you need to have at least evidence for these three tests: A1C testing, eye exams, and foot exams. And you see from these graphics here that the percent to which all three of these recommended tests are received is greater for whites than blacks, greater for whites than non-Hispanics, and greater in people with high income or with more education. In other words, people with less burden of the social determinants of health. Now, this kind of pattern extends across the spectrum of complications. Doesn't matter whether it's end-stage renal disease or coronary heart disease or amputations. And even as we look at the trends in recent years, which show that some of these complications are improving. We see improvement, for example, here in cardiovascular complications. But the rate of improvement, in other words, the decreased burden that is seen, is better for whites than for communities of color. So the disparities persist even as patterns of improvement emerge. Now, we see evidence of shared legacies when we see what's happening, for example, in Canada, which is my next slide, which is I have no idea why my slides are protesting this morning. We see evidence here in Canada of the same kinds of disparities. This is where I wanted to focus. The burden of complications is higher for people of the First Nations, the Inuits, the Métis of Canada. But the question again reduces to why. And there are multiple factors that are probably driving these differences in burden. Clearly genetics, environmental factors, physiological differences, but most likely in all of these instances, it's going to be multifactorial, even idiosyncratic, but for the most part, we are not quite clear, so there's a lot of unknown. What is clear is that the evidence from our shared legacies begin to provide support for the negative contributions of colonizations and the resultant legacy of racism, where you see now the creation of a setting and a set of conditions where factors that are generated have greater association with increased risk factors for cardiac disease, for example. Whereas the more we try to drive towards self-government, empowerment, we create conditions where there are factors more commonly associated with lower cardiac risk factors. And so we know what the factors are that contribute to the variabilities of these risk factors. The question that we have to ask is, why do we have these conditions and what can we do about them? Whether we examine these issues north of our borders or south of our borders, I really have to re-emphasize the centrality of the wealth gap. It is indisputable in the legacy of marginalization. And we see, for example, in Canada, that there is this wealth gap in the income status that is reported for Indigenous persons in Canada versus non-Indigenous, where you see the gap is appreciable in all cases, with the exception of the male Métis. So it's very clear that whether in Canada or in the US, the wealth gap is real, and you see much higher percentages of persons living in poverty based on race and ethnicity in the Black community, American Indians and Alaska Natives, followed closely by Hispanics. Now, even though the wealth gap can be mitigated to some extent by social dynamics like more education, it is rarely, if ever, closed, with those in the lowest strata always bearing the greatest burden, which is the legacy of this wealth gap. Now, these are major drivers of health disparities. The wealth disparities inexorably lead to greater and more frequent health disparities across a broad spectrum of conditions and diseases. So a more granular issue emerges, and that is how much of these differences are accounted for or driven by factors like biology, bias, behaviors, or other factors. We are really going to focus only for a bit on biology and bias. And I'm going to state my position on this straightway. And that is, the most significant changes that drive the current trends in diabetes, the disparities that we see in high-risk minorities, have some, but overall little to do with changes in the genes. Our focus should be, in my view, sharply on those elements of environment and behavior that we can modify, things that we can change, because that's where the potential for real change resides. Now, a variety of arguments have been made about the purported contributions of genetics to diabetes causality. Genetic factors have been considered as a potential explanation for racial or ethnic differences in diabetes risk. And of course, I'm preaching a bit to the choir because Bernie and colleagues over about 20 years ago did some really beautiful work on genetic variants in hepatic nuclear factor, which predicted with great specificity and great predictive power the development of diabetes by age 50 in the Oji-Cree tribes. But the majority of studies suggest that the genetic architecture that confers risk to type 2 is similar across racial and ethnic groups, at least for the common variants. Over 40 confirmed loci are associated with an increased risk for type 2 diabetes, regardless of race or ethnicity. And we have far too few large-scale genetic studies in such populations. That's where we really need more attention for novel discovery and focus in future genome-wide association studies for type 2 diabetes. But genetic differences have also been proposed as accounting for differences in treatment, in approaches, and outcomes as well. And we see this clearly when it comes to the emphasis on pharmacokinetics and pharmacodynamics, because these can differ fairly substantially in different populations. And genetic polymorphisms have certainly been seen in metabolic enzymes, in receptor expression and transport. There are marked polymorphisms between whites, blacks, and Asians, for example, in the family of adrenergic receptors. And there's a fair amount of contribution from genetics in the drug disposition arena. However, when the FDA looked at a variety of important metrics for the purpose of labeling new medical entities, the most frequent observation that they cataloged across all of these categories was that no information was available. So clearly there are huge gaps. When there was information available, then the most frequent observation was that in PK, there were no differences reported, or that efficacy was the same. And so there can be little doubt that genetics play an important role. And I pointed out the work of Bernie and his colleagues years ago in the actions and responses of various organ systems across and between populations, but they are not uniform, predictable genetic associations accounting for diabetes causality or responses to therapy across and between populations. I think that what we have is abundant support for the axiom that genetics may load the gun in diabetes causation and progression, but it's really the environment that pulls the trigger. Now, when I look at the most striking illustrations of the balance between genetic versus environmental control contributions of diabetes, the advantage seems clearly to environment. Two very rather illustrative cases are the Pimas of Arizona and Mexico and the Japanese of Tokyo and Seattle. Now the Pimas living there in the Gila River Basin in southern Arizona had been in that region for since 300 BC. They were farmers because of the access to the Gila River, but the waters were diverted because of the incursion of white settlers. There was a reservation established in 1859. The first case of diabetes was recorded in 1908. Joslin, 30 years or so later, documented 21 cases among the Pimas. And at that time, this was akin to the prevalence of the general population. But less than 20 years later, there had been a tenfold increase in diabetes among the Pimas. By this time, they were on the reservation eating government commodities, not the foods that they had grown by farming. And the prevalence had reached about 46% by the 1970s. There were some of the Pimas that migrated across to northern Mexico, continued to do subsistence farming. When they were examined, compared to the reservation Pimas, some 30 or so years later, there was an 8-fold lower prevalence of diabetes among those Pimas in northern Mexico who had migrated. But of course, they had markedly different diets, BMIs, physical activity, and so forth. Same thing is true with Japanese. As an example, immigration started in the 1800s. It was stopped by the government in 1924. Those second generation Japanese, the Nisei, had 2 to 3-fold higher rates of type 2 diabetes in Seattle than they did in Tokyo. They were more overweight than the persons in Tokyo, but not as much as whites. They consumed similar amounts of food as their compatriots in Tokyo, but less than in US whites. But they did consume more total fat and more carbohydrate, and less carbohydrate than those Japanese in Tokyo. Now, in both instances, these marked differences in type 2 diabetes prevalence occurred in less than 40 years. Genes don't drift in 40 years. This is not a case of genetic anything other than predilection. So what drives the balance between development and control of diabetes? Well, is it the biology and genetics or the environment or external factors? It looks as though the balance really is tipped towards environment and external factors, which in a way is kind of good news, because this represents a domain that we can actually take actionable steps. Now, when we look more deeply at other factors in the scheme of marginalization, we begin to appreciate that in terms of its contributions to diabetes, that it can be fairly complex. And this is represented by examples like this one. This is an interesting study, as it were, of 2 cohorts of physicians. One cohort graduated from an all-Black medical school, Meharry Medical College, and another cohort graduated from what was then an all-white medical school, Johns Hopkins, and they were followed for 23 to 25 years. At the end of that period, what had been observed was that the Black physicians during that period of time were free from poverty. So their marginalization, as it were, was not driven by, if you will, the wealth gap, but they lived largely in Black communities, received their health care from people who looked like them, and they had lifestyles that were characterized by things like little physical activity, increased smoking, and diets that were less than ideal. As a consequence, they had far higher rates of CVD, earlier onset of chronic diseases, high rates of diabetes and high blood pressure, higher incidence of coronary artery disease, and higher case fatality rates. So there is clear evidence from a variety of sources that there are a variety of factors, many of them what we would consider non-clinical influences on clinical decision-making and in driving healthcare outcomes. Many of these are patient-related, and I've just highlighted a few of them: socioeconomic status, patient's race. A patient factor that's often considered important is the degree of adherence to treatment or behaviors that may influence their adherence. Obviously, attitudes and behaviors matter a lot in terms of patient factors for clinical outcomes. But what about physicians and practices? Clearly, with respect to physicians, their clinical decision-making is heavily affected by things like their age, gender, faith, social background, and certainly their race, the type of practice that they're in. And one of the things that we give far too little attention to is the degree of cultural sensitivity, the degree of bias training, whether implicit or explicit bias training. We need more of this in people who are going to be involved in healthcare. Now, my friend Paul Douglas, who is a cardiologist in Atlanta, has reported on a variety of factors that are linked directly to physicians that account for the lack of success in controlling blood pressure and diabetes in African Americans, leading to poor outcomes. And at the top of this list is the expectation of failure. And what this is undergirded by are attitudes about motivation, attitudes about the expectation of poor adherence, about whether or not patients are going to be able to afford their medication, about the general notion that these conditions are harder to treat in African Americans. What this type of thinking has given rise to is a sense of patient devaluation. Now, this is very, very dangerous, because this kind of attitude can result in patients who are right in front of them, but they're not being seen, let alone being taken seriously. And this can have disastrous consequences. Now, you are no doubt aware of the heartbreaking story of this 48-year-old Indigenous man from Manitoba who came to the Winnipeg Health Sciences Center ER in a wheelchair, sat there in the line of sight of multiple shift changes of staff, and yet remained unseen. Because of cultural bias, he was assumed to be intoxicated or homeless or both. He was essentially ignored, denied assistance even after signs of deepening distress. He was vomiting and was in clear clinical distress. The formal inquest into his death required more than 4 years. Now, the reason, turns out, for his ER visit was that he had a treatable bladder infection. The likely cause of his death was sepsis, shock. The real cause of his death was that of racism. He was ignored to death. This is not, unfortunately, an uncommon story on either side of our border. Now, occurrences like this and the colossal impact of cultural insensitivity and bias has led to a number of professional societies devoting more time during their annual meetings and symposia to issues of cultural sensitivity and bias. And in fact, at the last year's meeting of the Rheumatology Nurses Society, just to give you some idea of how far this is reaching, there was major attention given to this issue. And they issued a statement that healthcare providers are urged to create culturally safe medical homes for all their patients. And one of their keynoters, Lynn Smitherman, said, racism in itself is a huge concept. Yes, we totally agree. But I would say that many people initially responded to this issue, and many of you have perhaps responded to my talk in much the same way, and that is asking, why are we talking about this? Why are we spending so much time on this topic? I think it's a fair question, but I don't think we're beating a dead horse. I think it's important that we revisit the various issues that speak to our sensitivity to culture and ethnicity, because it has more awareness and urgency than ever before. We're seeing greater racial and ethnic integration nationally, greater visibility of cultural variety, and a drive to accept the substance of difference. It does not weaken us. In fact, it makes our communities stronger. We are asking that there be greater acceptance of diversity in conduct and perspective, and greater appreciation of the role and impact of these factors in chronic disease management. So what we see when we think about the situation like Mr. Brian Sinclair, that was the 48-year-old gentleman who was ignored to death, this kind of thing helps us to refocus our attention on the degree to which the impact of culture on healthcare is often lost in marginalized communities. The delivery of care often occurs outside of where they live, is done by people who don't look like them. Resource limitations are often present and common. Health literacy is an important issue, and little regard may be given to the role of cultural nuances and practices, and insufficient effort is devoted to patient self-empowerment. Now, what do we do about it? Well, there are some models that give us some hints. And this is busy, but I just want to use it to point out that one approach is the approach of doing these targeted focus groups, where people have been deployed to gather information about what is broken in the eyes of and in the experiences of the marginalized affected persons. And then the information that is collected is allocated to a coding tree for these different healthcare experiences. And they are cataloged in particular buckets that essentially provide granularity to the issues that need to be the focus of our attention. And these focus groups have been quite useful. I think they serve as a model for approaches that can be used and can be very helpful and practical. Now, they've been done, for example, all over Canada with a variety of partners. And you can see they're small in nature, but they're providing some important insights. And the experiences that they're learning about have been clustered into 4 themes: colonial legacy of healthcare, the perpetuation of the inequalities, the structural barriers, and the role of healthcare relationships in mitigating harm. One of the things that's consistent across these sites was the issue of concerns about the root causes of mistrust of the healthcare system. And quotes have been generated like these. This guy said, "We got all the way there, and this doctor, it seemed like he was prejudiced or something. Oh, it doesn't look like there's anything wrong with you. Didn't examine my back or nothing and said, see ya." All the way to Vancouver for that. Some places you do get treated poorly because of our skin color. That makes me so mad. I feel like taking a knife and saying, look, isn't my blood the same color? Well, clearly our challenge is a complex one and a big one, is to recognize the value and impact of culture on health outcomes in marginalized populations. What has driven those disparities? What are the contributions of colonialism, bondage? What kind of healthcare system has emerged as a result of the legacy effects that have driven the easy formation of stereotypes and the practices of discrimination, denial of access, and poor outcomes that are generated as a result? We are trying to break this cycle. And there are, in fact, efforts that are underway that are beginning to have some impact. And we're talking about generating equity-oriented services. And the general approaches that are beginning to have some traction is the degree to which we form appropriate partnerships and initiate actions at all levels. Give serious attention and appreciation to local and global histories. If we don't appreciate how we got here, where we've come from, we cannot adequately inform what do we need to do to go forward from this place. And we need to always think about the unintended and potentially harmful impacts of each of these strategies, non-biological kinds of issues. And when I look at this long list, which I'm not going to go through, but the strategies that have been devised with indigenous peoples, what I can tell you is that some of these, in fact, most of these same strategies are the ones we use and adopt at Healing Our Village in Clayton County, where we are based, a county in Georgia with an 80% African-American population. It is not substantively different. So we are now finding out from a variety of bodies of evidence that when clinical conditions are addressed in the absence of bias, they are more fully and comprehensively evaluated. They're treated earlier and more aggressively. They're treated using the most effective agents and most effective approaches. And the expectations of outcome are the same because they're based on the condition being treated, not on the person. And there is likely to be a structured and thoughtful follow-up plan. Now, outcomes are certainly likely to be improved by mitigating the barrier of bias. The biology has been demonstrated to respond to thoughtful, responsive care. I am becoming increasingly a champion of the fact that we need to have bias training as part of our healthcare provider curricula. No matter what profession, if it's a healthcare profession, we need to have bias training as a core element of the curriculum. Because diabetes and its related complications are common occurrences in marginalized persons, whether they are derived from a history of oppression or bondage. Historical practices have led to the generation of this embraced misperception that dissimilarity is equivalent to inequality. Marginalization seems to be inexorably accompanied by a wealth gap that in turn drives and supports a health gap, particularly in diseases like diabetes. Now, this difference in outcome in healthcare that we see in diabetes, whether causation or treatment, definitely we see has genetic and biological contributions, but the dominant influence that drives differences in diabetes causality and progression strongly related to environmental and non-clinical factors, the domain where we can actually do something. Racial bias and cultural insensitivity reflect modifiable elements of diabetes healthcare that, in my view, must be a central focus in our quest to close the healthcare gaps in diabetes for marginalized populations, no matter where we find them. So let me thank you for your time and attention, and ask your forgiveness for the slide advance glitches, and to submit questions for the time that we have remaining. The instructions are right here. I turn it back to our chairman. Chaim, is it you or Bernie?
Me, Jim, thank you so much for a fabulous talk. The chat has already come in with such glowing comments. But and thank you for commenting on our work in a remote Aboriginal community, indigenous population, the OG Cree. One of the things I think we're missing is that the communities can educate us as to what are the appropriate solutions for them. The problem, or what we can do, is inform them of what has changed in the last 50, 60 years. So for instance, in Sandy Lake, diabetes was known as shogawapine, causes all kinds of problems, amputation, dialysis, and of course, it's a sugar disease. And the word sweet actually has a positive connotation. So as long as I don't have sugar, I'll be fine. And that was the misconception, because the consumption of lard and other extremely unhealthy components of the diet was just skyrocketing. And once they learned that it was the obesity epidemic that was happening in Sandy Lake that was driving the diabetes epidemic, the lard consumption went down. Once they learned that physical exercise was important, then they built a road, an old trail that wasn't used anymore because everybody had a car. You don't need a license to drive the car in Sandy Lake. And there's a big circle going from the northern to the nurses station. When they learned what the issues were, they were able to implement what was socially and community acceptable interventions. I don't think we do that enough. I think we could do that in large cities as well. And so the epidemic of diabetes amongst South Asians and cardiovascular disease in Toronto is real, but the solutions may not be our traditional medical intervention, even if we are more sensitive, but rather we need to speak to community leaders in the context of, fast food outlets that are in the community, what people are doing in the community, their lack of understanding. So, I think it is complex, but we shouldn't miss the opportunity of using the knowledge and expertise from the elders and the local leaders.
So Bernie, thank you for that. Let me just comment quickly on that, because this actually aligns with many of the things that we have been trying to do ourselves. And one, it's a matter of the partnerships that you make with trusted organizations in those communities, because
Right.
the voices that contain the knowledge that you're trying to impart is going to be accepted more readily when it emerges from those institutions.
Right.
So those partnerships are extremely important. Generating trusted voices. Back in the day when I used to have hair, I was at a barber shop one day getting a haircut, and they had a discussion about diabetes, and this room full of guys. And what they were talking about was completely wrong. It was totally misdirected. And I just decided I had to step in, and I did a harump and introduced, and and just started talking. They didn't know who I was, but I sounded credible. And and it was still, they listened raptly.
Right.
Then when I finished feeling smug that I had really made a contribution, the barber, Roland, interrupted and said, "No, that ain't right." And they immediately accepted what he said. So 2 weeks later, I went and I got with Roland, because I had to convert him to a trusted voice.
Right.
And then we have to do more of that.
Yeah.
And then generate learning tools that actually
Right.
make sense for those. But we should not dismantle the traditional medical offerings, because that's where we hope they land.
Right.
It's just that when they get there, they should be met with a culturally safe environment with
Right.
appropriate kinds of care.
So Jim, we're on the same page. And so what we really have to understand, like the barber shop for, African-American communities is an important place to intervene, because people meet there and do a lot of talking and are open. Same thing with the church or other places of trust within the community. I don't think we're doing that enough. And we have to spend more energy with that kind of strategy than the regular diabetes clinic. So let's see, are there other questions? Now, in the chat, I'm supposed to find some questions here where Christian.
Dr. Zinman, we had
Yes.
Dr. Raja, or Jay Raja, actually has a question. He has her
Go
hand
ahead,
raised.
please.
Thank you for the really good presentation. I work in the community. I'm a diabetes educator nurse, and I work with clients with severe mental illness and who are poor and marginalized. So I'm in the trenches, in other words. And so I totally understand about the issues of bias. It is one of the hardest things that we battle every day with our clients with is, for example, with people with severe mental illness, that capability to actually do a treatment. So the doctor doesn't actually prescribe the actual treatment that would be the best for the client without actually making a full assessment and seeing how they can be supported. So I think, it's great to have the knowledge of the determinants and what it's causing as the problem, but what are we doing on an actionable level to really cater to what the needs of the client is, where they are. And even I work with a lot of Hungarian population clients as well, and Tibetans and all the newcomers that come through Parkdale. So it is very challenging when you've got biases in the medical field as doctors or nurses or anyone who's actually seeing the patient in the clinical office and thinking that they can't do it or they're not capable of doing it because of the stigma that we carry, right? And we as professionals have to check ourselves every day, regardless of whether we've got it or not. And it's a reflective practice that we need to take in order to say, am I being biased in this moment? Because I've had other professionals say to me as well, if someone's got severe schizophrenia and they've been incarcerated, how do you actually deal with that when they come in to see you, right? In terms of, are you, now standoffish because you've read their notes and they've had a horrible crime event that they were incarcerated for. So you really have to take your biases off when you come in to see the client and really meet them where they are. And it's the actionable items that are vital, right? It's good enough for us to have the knowledge, but how do we then translate that knowledge to action on an everyday basis? And I get a lot of South Asians. I'm South Asian and I have diabetes on all the sides and I'm in my 50s and I've run away from diabetes. I don't have diabetes, but when I get a South Asian patient who's 40 years old and they're just on metformin and their A1C is 12, I'm like, what the crap? Get it down to 6.5, right? Like, so it's using those kind of things of knowing the cultural background and looking at the clinical markers and saying, you can do this, and acting as the go-between even to educate. And it's not only the populations of people who educate, but the people who are also in the diabetes world as diabetes educators who are in those cultural backgrounds as well that can inform decisions. So thank you for the presentation, because it was really, really good that the groundwork is being laid beautifully. But action items, please.
Yeah.
Well,
Thank you for those comments.
Let me
Jim?
just say quickly, because I know the time is waning. It's one of the reasons why I think in the culture of training where we now are asking people to be recertified, we have to broaden the notion of recertification as sort of strengthening your core skills. Well, one of the core skills that needs to be included in the quote recertification effort for all of us as healthcare providers writ large is bias training. Whether it's, you talked about the halo effect and the horn effect of bias, where you learn something negative about a person and it really prompts your bias. Well, there's a perceptional bias, affinity. We need to really be trained on how to handle those situations. And we have to create mechanisms, whether while we're in training or when we're established healthcare professionals. This is really work that's important for us.
Jim, thank you for such a fabulous talk. It's something that we're all trying to deal with, whether we're north or south of the border. I think these are issues that are front and center, and I think we are making progress. I think you indicated that. And just to reiterate, the solutions are not simple. The solutions come from the community. The solutions come from how we train our residents, medical students in a different way, and hopefully we'll have equity and better care for anybody in a healthcare system in Canada that we're so proud of, but we still need a lot of improvement.
And I would say, let's not run from uncomfortable truths. It confronts us all.
Absolutely. So Jim, thank you again. We wanted to have you here.
Yes.
Well, you still owe me lunch, okay?
I do owe you lunch.
Thank you.
He certainly had a lot
Wonderful.
of Canadian information.